Good day, everybody.
No.
This is Joe Gallo. I have a couple administrative things I'd like to be able to manage before we get going, and we'll get well into the session. This is going to be, excuse me, another segment of AS101, which is sponsored by the Active Surveillance Coalition, and today being presented by ASPE. If you would, in your name display on the online, if you could indicate your country or city and state, that's just helpful so that we get an idea who's with us. I'm going to ask you now to please turn off your cameras and mute your systems, and remain that way throughout the presentation so that it doesn't become a distraction, because we do expect a fairly large attendance, and watching people either wave, sleep, or eat is sometimes a bit distracting. If you have any questions that come up during the presentation, you can put them into the chat, and the moderators will manage them. There is a possibility that you may get invited to open up your camera or microphone to participate, but please don't do that until you're invited to do such. Okay, and then the only last thing I'd like to mention is the standard disclaimer that anything that is presented today or that you hear today, and any of that information is intended to be informational. It is not intended to be any sort of medical advice. If you find anything that is of that interest, we suggest that you contact your medical team and pursue it. And with that, I will pass it off to Mr. Howard Walensky.
Hey, thanks for showing up, everybody. I'm one of the founders of ASPE, and I've been on active surveillance for almost 13 years. And in the Jewish religion, I'm approaching my Praz Mitzvah. Our fearless leader, Mark Lichty, chairman of ASPE, couldn't make it today because he and his wife, Wendy, are celebrating their 50th wedding anniversary in India. So send greetings to Mark if you think of it. I'm going to introduce this program, but what this program will be made of is largely a video. We're premiering a video in the Active Surveillance 101 series. We'll follow it with questions and answers and discussion. We hope everybody who wants to will interact with us and support. About a year ago, some of us involved in active surveillance support met to discuss programming for 2022. The idea was to try to avoid duplication through cooperation among support groups. We all agreed that we had a problem. And the problem was we were not connecting as much as we felt we should with the newly diagnosed and the people who I say are in the gray zone. They have rising PSAs, but they haven't had a biopsy, so they haven't been diagnosed with prostate cancer. So we wanted to reach out to those groups, those individuals, I should say, and Phil Siegel from Prostate Cancer Support Canada came up with this idea for this class that we call Active Surveillance 101. I'm not going to say that it's pass-fail, because everybody's going to pass. There's no grades, there's no quiz. We're trying to help the newbies or people on the brink of being newbies find their way in the middle of the night when there is no support. And so the videos from this so far have been posted at ASPE. This will be the third in the series, and we feature speakers. We try to simulate a meeting between patients and expert doctors. And our model couple are Larry and Nancy White. Larry has prostate cancer, and Nancy's a rather expert spouse, or she's an expert compared to anybody as far as researching prostate cancer. And so the Whites appear in all of the segments, and they simulate a visit. The first program was with Dr. Spann, who's a family physician. Most of this adventure starts with a family doctor who has ordered a PSA. And so we start there with Dr. Spann with the rising PSA. Then we go to Dr. Klotz and the whites. And Dr. Klotz is at the University of Toronto and is considered the father of active surveillance. And so we have two segments with Dr. Klotz. The first one was more or less a continuation of what's going to happen when you have a rising PSA and you have your first urologist visit. The session today is going to be focused on questions the whites have once they get the news about the biopsy and active surveillance. Any rate, so that's the program today. We have three others in the can. We have an especially good one coming up. Of course, they're all good, but this one's especially good with Dr. Epstein, the top gun of second opinions on biopsies. And that's being edited now. We have two other programs on genetics and genomics testing. And we have one more to do, and then we'll see, what happens after that. And so, just to give some credit here, the Active Surveillance Coalition, which developed this series, is made up of ASB, ANTCAN, Prostate Cancer Canada, the Active Surveillor newsletter, with technical support from PCRI. Let's see. I have notes, but I've kind of faked my way through it without the notes. So I guess it's time for Bill to make it roll, let it roll. And then after that, we'll open up to questions. Please put questions in the chat box. Don't make it too personal. We can't give medical advice. But Bill, on with the show.
Welcome. I'm Joe Gallo of the ASPE board and also an advocate with ANTCAN. And we're here today as part of the Active Surveillance Coalition. We are presenting a series of videos to provide information for men and their partners. We assume these men have rising PSAs with suspicion of prostate cancer. Our actors are real physician experts and real patients and their partners. Our program today is the biopsy report featuring Nancy and Larry White and urologist Dr. Lawrence Klotz of the University of Toronto, otherwise known as the father of active surveillance. In the second part of this program, our patient Larry has done imaging and undergone a transperineal biopsy. Larry and his wife Nancy are meeting with Dr. Klotz to review the biopsy report. Let's join the program.
Good morning, Nancy and Larry. Good to see you again.
Good to see you.
Good to see you.
I hope.
I take it you survived the biopsy all right?
I did. It wasn't as bad as I'd anticipated.
Okay. So we're here to discuss the biopsy results. And this is kind of a good news, bad news story. Mostly good news, as you'll hear. But, to begin with the bad news, we did find prostate cancer. Was a positive diagnosis. And the rest of the story is a pretty good news. So you have what is called Gleason 6 prostate cancer. The new term for this is called grade group 1. So the grade grouping goes from 1 to 5, and you are at the most favorable end of that scoring system, group 1 out of 5. The other term you might hear about this is called Gleason pattern 3, and the pathologist looks under the microscope and looks at the commonest and the next most common pattern. In your case, it was all pattern 3, so 3 plus 3 equals 6, which is actually the lowest Gleason score, and therefore we now call it a grade group 1.
Okay.
So while you have been diagnosed with cancer, grade group 1 is not a cancer the way most people think about it. The first thing to appreciate is that grade group 1 prostate cancer develops in most men with age. It's really a normal part of the aging process. And the likelihood that at your age of 70 that you would harbor some grade group 1 prostate cancer is about 2 out of 3. In other words, 2/3 of men have this, they just don't know they have it. Okay, so that makes it very different from what people normally think of. The word cancer evokes a kind of aggressive, potentially lethal condition. You simply do not have that.
Right. Well, I'll tell you, when my dad had cancer, I thought, if I find out I have cancer, I'm having surgery, I'm having the thing removed.
Right.
I mean, my thinking has changed a little bit, but
so let me tell you a little more.
Something different from you now, I think, than maybe my assumptions.
Right.
For this.
So that's a very common initial reaction. But let me just take you through this a little bit more. And I am fairly confident that you may change your thinking about this by the time we finish this discussion. So just a few more things about what you've been diagnosed with, this grade group 1 prostate cancer. I refer to it really as a pseudo disease or a pseudo cancer because it really is part of the aging process. Now, could this spread? The answer is no. Grade group 1 cancer has normal molecular genetics. So in almost 100% of cases, around 90 to 95%, there are none of the genetic abnormalities that are associated with higher grade cancer are seen in the vast majority of patients with grade group 1 cancer. And the effect of that is it's a completely non-metastasizing cancer. There are almost no cases anywhere in the world of a pure grade group 1 cancer that has actually gone on to spread to the lymph nodes or the bones. Okay, so really what we know you've been diagnosed with poses absolutely no threat to your life.
Okay, well, when we did the MRI, did it show that I had a potential cancer? We were talking about that score. I don't remember exactly, 3 or 4 or something, but did the MRI give you an idea that I might have cancer? And
your MRI did show a 4 out of 5, small 4 out of 5 lesion. It was only about 8 millimeters in diameter, quite small as these things go. That is what we targeted, and we did find the grade group 1 cancer.
Okay.
Now, just to fill out the picture a little more, as I mentioned in our first discussion, certainty in medicine is not the norm. And the uncertainty in this case is that you're being found to have this low-grade prostate cancer means you could have something more that we don't know about. And the risk is somewhere around 15 to 25% that there's a higher grade cancer somewhere in your prostate that was missed on the biopsy. So the approach that I believe is warranted in your case is not treatment, because we're treating a condition that's really part of the aging process.
Okay.
It's monitoring, and the approach is called active surveillance. And the idea is we would repeat your PSA about every 6 months to see if there's a progressive rise. You would have another biopsy in around a year. And we would also follow you with imaging after that to see if there's any change in what you have. And the experience we have with that, and worldwide, there's now more than 10,000 patients who've been followed this way, like you, grade group 1 prostate cancer. Many of them have other risk factors like a family history. And we know the safety of this approach, even though some of them harbor higher grade cancer, is really very, very high. So the risk in a case like yours, like there is a higher grade cancer that we've missed, and during the observation, this will go on and spread and metastasize, is less than 1%. over a 10 to 15 year period.
Mhm.
So, my advice at this point is very much not to go the route of having it out, but to be managed with this conservative approach. It doesn't mean sending you out into the wilderness. We keep a close eye on you with following the PSA, repeating the imaging, repeating the biopsy in a year, and then every probably 4 to 5 years after that until you get too old to worry about it. And I can tell you that this approach is really effective. The likelihood that you would actually end up having an adverse prostate cancer outcome is very, very low.
Okay, I mean, do you, the people who read the slides, the people who read the biopsy, can there be variation in the person that reads the biopsy in terms of, in other words, if one reads it 3 plus 3, what I think, might another one interpret it differently?
Yeah, so pathology is both an art and a science. There isn't complete concordance. The disagreement rate is somewhere around 20% on average. Usually, though, if there is a disagreement, it's just by one Gleason score. In other words, you might have a small amount of Gleason pattern 4, according to another pathologist's interpretation. In general, however, when the slides are read by what's called a GU pathologist or genitourinary pathologist who specialized in the area, that discordant rate is a lot lower. So there's really no issue about getting a second opinion on your pathology slides if you wish. We'd have to go back and see, was it read by a kind of subspecialized GU pathologist? If that's the case, in my opinion, it's really not worth it. That the confidence in their opinion is really quite high. If it's a general pathologist, it's a fairly easy thing to go ahead and get it re-reviewed by a subspecialist.
Okay, that makes sense. Okay.
There's another aspect to this that we should discuss, and that is the issue of your family history and whether you have a genetic predisposition to a more aggressive type of prostate cancer. There are some specific. There's a specific family of genetic mutations, and it relates to something called DNA repair defect. So we have learned over the last decade or so that particularly in families where breast and prostate cancer are common, that a proportion of them have this variant or mutation in a gene called BRCA. And so before we get too far along, one thing that you would need to do is, particularly with your family history, but even without it, I encourage patients like you to be tested for this. The testing is quite inexpensive, a few $100s. If you have a BRCA mutation, it's a different discussion because those patients tend to get more rapid progression of disease. But the chance is roughly 90-95% that you don't have that, despite your family history. And then really the active surveillance approach is the one that makes the most sense.
Okay. And then also, what about, that would be genetic testing, I guess. And then what about genomic testing? Should he? So
if by genomic testing, you mean testing the cancer?
I'm not sure what I mean.
Okay, so I'm not sure your lingo is correct. Genetic and genomic to me pretty much means the same thing.
Okay.
So the distinction is between germline testing. That's to see, do you have a genetic predisposition for a more aggressive cancer?
Right.
Okay. And again, in families with a lot of breast and prostate and some other cancers, this is more common, but overall, most patients don't have it. Most patients are normal in that regard. And, it's just one of those facets of your case that we should ascertain. The genetic testing of the cancer is another story. Mm-hmm. So there are now about 4 different molecular tests where what's done, it's a commercial laboratory that micro dissects out the cancer cells and subjects it to genetic analysis. You could do that. It's relatively expensive. The cost is somewhere around $4,000. Your insurance may cover it. I can tell you, I'm here in Canada, it's not covered at all. My view is that while it may provide some further information, the majority of patients like you with grade group 1 prostate cancer do not require this, because the risk of your having an aggressive cancer is so low. We can lower it further by following the imaging, by repeating the biopsy. It's really the rare patient in your situation where the genetic testing really tells us that there's something worse going on. And without the molecular assay, the metastasis rate is still in the range of 1% or less. So there's really not that much to gain. Now, if the next time you have a biopsy, you turn out to have some higher grade cancer, particularly if it's grade group 2 with a small amount of pattern 4, then that's the sweet spot for the test, because you may still be a candidate for conservative management. Most patients with the grade group 2, particularly if there's a small amount of the pattern 4, it's a 3+4 or Gleason score of 7. If there's a small amount of pattern 4, most of them still have very indolent, slow-growing disease and still don't need treatment. But there is some of the pattern 4, it's a real cancer. So that's kind of where this molecular genetic analysis really, in my opinion, has a much more important role.
Well, if the PSA continues to rise, would that indicate also that there might be some pattern 4?
So the PSA is kind of a fickle partner in this setting. First of all, it bounces around. So yours was 6. The between assay variability is up to about 1/3. So it could go up to 8, down to 4. That would just be considered biologic noise. So if it doubles over the next year or 2, that's definitely meaningful. We would increase the intensity of the imaging, perhaps an earlier biopsy than we would do otherwise. But it's really the imaging and the biopsy that tell the story. The PSA is really just a guide as to how closely you should be monitored.
Okay.
That's a change. Early on in this trajectory, we used to treat patients just on the basis of a rapid rise in PSA, and patients on surveillance, that is, and that turned out to be the wrong strategy. We overtreated a lot of people just because their PSA jumped up due to inflammation in the prostate or infection they sometimes weren't even aware of, and we treated a lot of patients who didn't need it. It took about a decade to figure out that actually the PSA was not a reliable indicator of disease progression.
So the active surveillance does seem like a reasonable approach for us right now, from what you're saying. And
100%, I agree with that, yes.
And I guess for me, it's that balance, it's like, you don't want metastasis. You don't want a higher grade cancer hanging out someplace in the prostate, right? So it's like trying to figure out when you cease to do the active surveillance and move toward treatment. I guess that's on down the road, but that seems like a critical piece there.
Well, just a couple of points. First of all, if treatment of prostate cancer was like an appendectomy, where you had the procedure, the incision healed, and you're completely back to normal, then there wouldn't be this interest in active surveillance. Like, why not treat it just in case? The problem is that certainly the radical treatments for prostate cancer, by which I mean removal, radical prostatectomy, whether it's done with the robotic technique or the older open technique, or radical radiation. And you have to deliver quite a high dose of radiation to the prostate to be effective. They both have significant effects on quality of life. They affect erectile function. The surgery frequently affects continence. The radiation can affect the rectal function. Patients who have those are at risk for quality of life effects. And there's nothing wrong with that if you have a life-threatening cancer.
Right.
You pay the price. definitely worthwhile. But for basically a cancer that has essentially zero likelihood of being lethal, and you're treating it just in case, it simply does not make sense, in my
Right.
opinion.
Mhm.
There are the alternative would be in a kind of emerging area, which is called focal therapy. And, I would say if, for example, you are in the situation where your PSA is rising down the road, let's say the image on MRI starts to look, or micro ultrasound starts to look worse, larger, more intense, and you're getting worried about it, some kind of minimally invasive therapy that doesn't mess with your quality of life too much maybe makes sense, if only to put your mind at ease. So that's the kind of scenario where I could see some intervention being justified. But short of that, frankly, at this point, you don't need anything further.
Okay. Okay. And that makes sense. So that's on down the line.
Yeah.
Yeah.
The other thing I would add, by the way, just to close the circle on the BRCA testing, if you are BRCA positive, then you should be treated, and probably with surgery.
Mhm.
So I think radical treatment is warranted even for grade group 1, because while it's grade group 1 today, almost all patients progress to higher grade cancer over time.
But I hope that doesn't come out positive. But I mean, how does that impact our children? I mean, if I'm positive, let's just say I'm positive,
Yes.
do they need testing, or what? Where do we go from there?
Yeah. So, I mean, one of the benefits of your being tested is that it definitely has ramifications for your immediate family. So, I mean, it's a, you have a 50% chance of passing the gene onto your children, and therefore they should be tested. Now, the impact of BRCA tends to kick in kind of in midlife. But yes, if you're positive, for sure, your children should be tested as well.
Okay.
Okay. All right.
Just another aspect of this whole issue of progression I just want to touch on is, I mentioned that there's somewhere around a 20% chance of your harboring higher grade cancer. That's the rationale for continuing to re-image and rebiopsy within a year.
Right.
Once we're confident you don't have anything further, then the issue becomes disease progression over time. So, biology is dynamic. Things don't tend to stay the same. And there is a small chance that over time your grade group 1 cancer will de-differentiate or become or turn into a higher grade cancer. And just for your information, the risk of that is estimated to be somewhere between 1% and 2% per year. So in the short term, it's kind of a non-issue. You and I will get to know each other quite well. So, I'm going to see you once a year for many years. And, so it means in the 10-year time frame, there's roughly a 1 in 5 chance that you'll progress to a higher grade cancer. Now, that's not as bad as it sounds, because in 10 years, you'll be 80. Most of the patients who do progress by 1 grade group. So you'd progress to a Gleason 3+4 or a grade group 2. That's still not much of a threat once you're 80 years old. It still tends to be a kind of a slow growing cancer. So it's just something to be aware of. This just emphasizes the importance of long-term follow-up. And if you were one of those guys who in 3 or 4 years were found to have a higher grade cancer, then the options are, depending on your age and your health and the extent of the disease, surgery, radiation, one version of focal therapy or another. Overall, historically, about 1 patient in 3 like you ends up being treated. But a lot of that data comes from an era before we had the imaging that we have today.
Mhm.
So my estimate is, in your case, it would be, again, assuming you're not BRCA positive, it would be maybe a 1 in 5 chance over the next 10 or 15 years that you would require some kind of intervention. Most patients never need treatment.
Well, and I'd rather never need treatment. So I think, again, the active surveillance sounds like a very positive way for me to go. I guess it depends upon how anxious anybody is, but I think I can suppress my anxiety, to go ahead and do the active surveillance with the follow-up and everything as you suggest, and go on from there. What do you think?
I think so. And also the science is progressing so quickly, and new tests and new, like you mentioned, the PSMA test, and there's so many things that, could even aid in diagnosis in the future.
That is really an understatement. The field is really on fire. So just a couple other things I'll mention that I think are very much on the horizon. One is it looks like there will be some urine-based markers that are very sensitive for picking up higher grade cancer. And so imagine I think it's very plausible during your period of surveillance that we'll be able to replace the imaging and certainly the biopsy with just a urine test. And as long as it's giving us a negative readout, you just carry on. If it switches and says, oh, there's something going on, then it's another story. That's one very significant advance. And I also think, as you mentioned, PSMA, it's only going to be a few years, I think, before this is now very widely available, perhaps for all patients who are diagnosed with prostate cancer. And that's complementary to the MRI and ultrasound. And if that shows a very strong signal, there's some recent data that in patients who have a positive PSMA and a very positive MRI, that virtually all of them have significant cancer. So I think that's another direction this may be going. We're not quite there yet, but it's really around the corner.
Okay, well, boy, that's a lot of great information. And so I guess we're going to proceed with the active surveillance, and I guess we'll be seeing a lot of you.
And a genetic.
All right. Well,
Yeah,
so you're going to have the bracket test. We're going to set up the MRI for about at least the confirmatory biopsy, pardon me, for around 9 or 10 months from now, and we'll be in touch.
Sounds good. Thank you so
Thank
much.
you.
One other thing I'll just add is if as you're thinking about this, you have some other questions, I'd be happy to talk to you again.
Okay, great.
Great, thank you.
I'd like to thank Larry, Nancy, and Dr. Klotz for this very informative presentation. Thank you also for attending, and hope you found this video beneficial. Please join us for additional programs in this series.
Well, thanks everybody for joining us. Very soon we will post the video online. I already posted where you'll be able to find it. I think at this point too, I should mention the ANCAN support group is having a webinar on Monday at 8 p.m. Eastern. featuring Dr. Schultz, the author of The Invasion of the Prostate Snatchers. And, we'd like to have you join us then too. And I'm going to put that in the box. I also wanted to take note that this group has served patients in more than 20 countries, and today we can add another one, Russia. So we have a visitor joining us from Moscow. I don't know if he would want to say a few words about what brought him here and how he even heard about this. But meanwhile, I guess we can open up to questions. Let's see. I don't know if Jim Strait is able to join us too. Jim? And Bill and Joe, should we have the participants ask their own questions?
Well, we could do that based on an invite, though. I think you or Bill or Jim should then identify who it is, because otherwise we've got well over 100 people online with us, and that
Well,
otherwise,
I could start out with my fellow Chicagoan, Michael Meschenberg. Michael, you had a question. Do you want to pose that?
Sorry, I had to unmute. Thank you. I wrote in the Q&A, but I forgot. I think I wanted to know the distinction between a Gleason 3+4 versus 4+3, which I understand are important distinctions. Can the doctor or somebody explain the difference and follow up with possible treatment if necessary?
Well, let me point out that Dr. Klotz is only here on memory.
video,
He's
yeah.
not here in person. Joe, you might be a good one to take that.
yeah, I can pick that one up. When you look at the score, 3+3, 3+4, 4+3, what you're looking at, the first number is the most prominent pattern of cancer cells based on the biopsy. The second, after the plus sign, is the secondary one. So that would be anywhere from 49% to less than half. So when you're a 3+4, the most prominent is a 3 with a percentage of 4 there as well. The 3 is the prominent one. If it's 4+3, you have an indication that your predominant is 4 with some 3 present. And the 4, as the doctor indicated in the presentation, the 4 is the more concerning cancer. The 3 is usually somewhat what they call indolent. You can live with 3+3. If it's true 3+3, you can live with that for forever.
Thanks, Michael. Maybe I can ask Anthony Henry from the Walnut Foundation in Toronto to pose his question about focal therapy. And I think Jim Schrate, who wears many hats, if he's able to respond to Anthony's question.
Yeah, so my question was, Dr. Klotz mentioned focal therapy. My question is, are there different types of focal therapy? Are there side effects to focal therapy?
Yeah, Jim, can you field that?
Yeah, I can. I think there are several types of focal therapy. They use cryoablation, which is actually freezing tissue, and then HIFU, which is high frequency microwave. But the essence of this kind of treatment is that there is real-time imaging, and they look for the actual tumors and then ablate those tumors and a space around them. It's relatively new. The FDA has approved some of the devices, I think both cryoablation and HIFU, but it really has not reached mainstream use in the United States. And I think part of that is because the urologists are very conservative, and it hasn't been proven and doesn't have the kind of track record. But the goal of focal therapy is to remove as little of the prostate and adjacent tissue and structures as possible, with the goal of preserving quality of life, as well as controlling or eliminating the cancer.
Howard? Yeah, Jim, in terms of focal therapy, I think there are international differences with it. For example, Dr. Klotz is a big fan of it. I know in England, they seem to be doing a lot of it. It's been adopted later in the US. But Jim, what do you recall from the American Urological Association guidelines? They're kind of conservative about this, right?
Yeah, I'm going by recollection here, but they typically don't recommend it. They say, you basically you can try it if you want to, but in their mind, it's still experimental.
I got you.
Howard, there's also in that category, there's laser ablation. In fact, in Southern California, there's a group that does perform that, and they've got some clinical trials that have been going on for quite some time. So it still does come under that experimental category. But of course, another big roadblock is that insurance won't pay for it. So it's out of pocket, and it's a lot of out of pocket. So that's the other issue.
Well, I have heard of Medicare covering it, but I don't have the details. There's another fellow patient who actually was a medical, he was a biostatistician, and he did his own study on this. He concluded that focal was best for him, and he was able to make his case to Medicare, but it was really difficult. And it's about, I think, $25,000. And we've also heard a tale from a young man who got diagnosed like with a single lesion by a private practitioner who told him he would benefit from this. And so he paid $25,000 out of pocket. And what happened next was he grew a lesion on the other side of the prostate. So he'd been sort of fleeced. So you got to be careful with this. Let's see. We're starting to get more questions up, although we're hands up. So it'd be good to enter your questions.
Howard,
yeah,
there was a question earlier in the morning where someone asked about Peyronie's disease. That could be a result of a needle biopsy.
Yeah, I saw that question, and I don't have an answer. Do you?
No, I don't.
I don't know. I mean, I'd seen another question, whether biopsies can cause erectile dysfunction. I know the doctors say no, and there's another question which you get mixed answers on. Can biopsies spread prostate cancer? And I think the answer on that is generally not. But Peyronie's disease, I don't know. I mean, there's a certain amount of trauma, with the biopsy. But Peyronie's, I think, affects the tissue on the penis per se.
Right.
Biopsies coming from the other direction. So, and I don't play a doctor on internet or on TV, but there may be a distinction there. It's a good question, but I don't know the answer.
The needles in the biopsy that do not reach to the penis, and it's usually then a buildup that causes the Peyronie's. So that's from what some of the presentations that I've been able to attend. If you still have that particular question, even after our attempt to try to answer it, send us a note and we'll pass that along to the doctor.
Well, yeah, we're having this session on Monday. We are, I don't know that excuse me, but Joe, we've had about 40 questions already. We may not have enough time for the doctor to speak, because other than answer questions, but feel free to send Joe or me an email, and we can add you to the list. Man, we got a lot here. Steve Hammaker, do you want to? It looks like you may have one or two questions. Steve, do you want to say anything?
I'll just say to each one of you that organized this and that are behind the scenes participating over months, if not years, thank you immensely. More so for the people at medical centers, support groups I've gone to that don't have the support from the medical center. for the amount of information that you put out and have been putting out and will put out. The question regarding density level didn't come out in his video. It's all important. You can have, as you guys would tell us, a bad scenario with your cancer, but you got such a big organ, you don't have to react immediately. But it should be the knowledge of every male as to what his density level is. Why is that downplayed in the video?
I don't know that it is downplayed. You know, there was a lot covered in there. For some reason, the density issue didn't come up. So, you know, again, we can add that to our list with Dr. Schultz on Monday. But some doctors may use it, may not even, you know, they just do it automatically, Steve. So I can't account for your, you know, for an answer to your question, but, you know, we can ask it again. I don't know if any of the other moderators have anything to say about density. I know my density is low. I'm trying to talk about my brain. I don't know, but anybody else? Jim, do you know much about density?
I don't know a great deal about it, and I don't think it's been subjected to rigorous research. I'm not aware of, you know, clinical trials or studies out there, but, you know, I may have missed it. In my own case, they did do this, and, you know, it indicated more serious disease. I think, you know, as Joe frequently says in our meetings, it's not just one factor that you need to look at here. And I think density, PSA, imaging, all of those things, and potentially genomic and genetic testing are all very important. There's no one element here that's going to give you a concrete answer, but if you bring it all together, it's going to point you in a direction at least.
Howard, I believe one of the issues regarding density, you know, whether the 0.15 marker is, you know, in stone analysis or not, but I think one of the things that the density brings out is the size of your prostate and how that affects your PSA, so that someone with a small prostate that has a high PSA versus someone with a large prostate and high PSA is really two different scenarios. So having the density reading, I think, kind of helps explain for some of us, myself included, why your PSA is so high, and not taking that to the next unnecessary step of assuming it's because of cancer.
That's correct, Bill. That's a good presentation of it, because as we get older, our prostates tend to enlarge, and as they enlarge, they generate more PSA, and that's why they use that calculation. But again, you know, as we're quoting Dr. Schultz and Klotz both say the same thing. PSA is a check engine light. It indicates that you need to look at it. It does not mean that you necessarily have cancer or that you need treatment. Howard, we also have a question. Mike Little's been holding for us.
Sure.
Hi, can you hear me?
Yeah.
Yep.
Okay, hi. I'd like to agree with Steve. Thank you for this forum. It is so helpful mentally, and the information that has obtained. I have a little different question. Has there been much research yet on nutrition regarding diet with prostate cancer? I know that tomatoes and broccoli sprouts, those are anti-inflammatories and they tend to fight cancer cells. Do we have more information
Well,
yet?
you know, there's like 1,000 answers to that. You know, I got diagnosed almost 13 years ago, and that was the first thing I asked my doctor, you know, is there something I can do with diet? And he said no. He enrolled me in a study at University of California, San Diego, called the Meal Study. And it was a big study and it was a big flop. You know, it seemed to, just be kind of non-specific about vegetables being a good idea. So there's been some recent studies, and you can find a number of webinars that have been held in this group and in the ancan.org group. Maybe we'll be able to dredge some up, or if you want to send me an email, I can dredge them up for you. Like Stacy Loeb, Loeb, at NYU, New York University, just released a study showing the advantages of plant-based diet. There seems to be increasing evidence for that. But on the other hand, I was on a panel with the doctor who is in charge of prostate cancer for the National Cancer Institute. I can't exactly remember his name. His name is Howard Parness, I think. And so somebody asked him about diet, and he said, we've been trying to nail this down for 30 years, and we don't really come up with anything. So we had another presentation at the ANCAN group, a doctor from MD Anderson, and he found the benefit of the Mediterranean diet, which is, not much red meat, fish, fruit, vegetables. And that's kind of the typical recommendation if a doctor makes one. And so the Mediterranean diet is a heart healthy diet. And I'm not being a doctor here, I'm just giving you some advice as a friend. But if you follow something like the Mediterranean diet, it will help your heart. Anything that helps your heart is going to help your prostate. And, we're all here bitching about our prostates, but the big threat in our lives is really heart disease. So I don't know if that answers your question, but that's my two.
Howard, one of the common threads that goes through all of the presentations that, that you and I and others have put together, Bill, and all, and the one seems to be the common statement is heart healthy diet is probably the best main line to go with, whether it's any one of the particular diets. And again, as you directed, they could go to either the ASPE or ANCAN websites. We have several presentations by some of the experts that would amplify that.
Something else I would add too, and we've had presentations on this as well. More important than diet is exercise. So, stick with your exercise, or get on board with exercise. It's good for your heart. It's good for your prostate. So, but maybe we should move on.
Howard, Anthony Henry has a comment for you as well.
Sure, Anthony. Anthony?
Sorry, there was a question in the chat earlier about perineal involvement.
Oh, perineural. I've written a lot about that on my newsletter.
Yes. Just wondering if you could comment on that.
Why don't you comment on it? It's not, generally, I don't think it's anything to worry about. It's hard for me to break away right now, but I wrote a series of 3 articles about it, talking to experts. I mean, Joe, maybe you could throw in something that is really more of a threat.
Well, what I was going to suggest right there, which we know because we were at the taping, that is addressed by Dr. Epstein when he does his video with us on the AS101.
Yeah, I mean, I really have to look up the perineural invasion. It's different than the prostate snatcher invasion. It's a different invasion altogether, but it sounds worse than it is my recollection. if I get a chance to break away, I'll try to find something about it. What about, I'm going to have a little bit of problem pronouncing this, Willia Shavel. Willia, do you want to say something?
Yes, thank you very much. Very informative morning and appreciated. Two things, I guess. The association's probably online and I could join it, hopefully. And then the second real question is, I've had diagnosed prostate cancer for probably about 14 years. And I was wondering about going forward with biopsy. It's been a long time since I've done it. I'm over 80.
Oh, you're
And,
over 80. Where do you live, by the way?
Boston, Mass,
Oh.
and I'm being treated by Dana-Farber Cancer Center. A doctor.
Yeah, you're in good hands at Dana-Farber. You know, this whole business of age 80, for example, I mean, this group typically goes down to age 50 all the way up to pushing 100. And there's a lot of opinions about age. I'm 75. I've been on active surveillance for 13 years, but my
Still a
surveillance,
young man.
well, I look up to my elders, you know, but
Thank you.
my situation, for example, has shifted. I mean, but I have very, very low Gleason 6. I mean, it's only been seen once. And I've moved in, okay, you know, there's watchful waiting, which they did for years. And a lot of people died because there wasn't enough watching and there was too much waiting. So Klotz and others in the late 90s started to do active surveillance. You know, it's for the Pepsi generation, a lot more testing. I've sort of shifted into an area in between. I call it passive aggressive surveillance, because at this point, my doctor only wants to follow me once a year. And if I have a type of PSA called the Phi test. If my Phi test goes up, then he would consider a biopsy. And if the biopsy showed, you know, like something more aggressive, like a 4 or a 5 PIRADS, then he would consider acting. So, you know, part of what these doctors do when they evaluate you, you may not know it, but they kind of figure, you know, do you have 10 years left to live? And they make their recommendations on that. So there's two guys who frequently come to our support group at ANCAN, which is a different organization that some of us with ASPE are involved with. We have one guy who's 84, and, you know, here's the way he talks. Well, you know, I've had a good life, but, you know, maybe it's time for me to stop this active surveillance stuff. You know, do I need any more biopsies? Then there's another guy who's a little bit older, and he says, I want to be on active surveillance for the rest of my life. He said, so some of it is your own attitude, some of it is your doctor's recommendation, and you're going to need a meeting of the minds on it. I was talking to Dr. Cooperberg at UCSF, in San Francisco. He said he had a patient, or he has a patient who, as I recall, is 101 and is still on active surveillance. But the problem is he's lived so long that he has started to develop.
No need leaving it on for me to catch a glimpse of what you're listening to, because I don't care.
Well, it didn't go off. I had to shut.
So he's 101, and now he's developed a more aggressive cancer. So, you know, you takes your chances, you go with the odds, and you try to make the best decision. So so your question is, after 80, is biopsy discouraged? Depends who you talk to, and it depends on your own attitude. 184-year-old says, I'm done with them. I'm 75. My doctor says I'm done with them. one other 85-year-old says, you know, he wants to keep this up for the rest of his life. So, you know, I suggest, I don't know if anybody else wants to chime in on this, you know, Joe or Bill.
Watchful waiting for me will be when I'm 99.
Well, let me ask you guys about what my doctor is doing, and my doctor is Dr. Helfand here in the Chicago area, and he's a guru on genetic testing. But you know, he's putting me on this passive aggressive approach. So I'm not doing any more biopsies unless my PSA goes up. And he's comfortable with that. So what do you guys think? Am I in danger, or what do you think?
I think the thing that's most important, Howard, is if you're on active surveillance, you're active. Don't go sitting back and just say, well, okay, I've been doing okay for the past few years. I'll just let it go. Because then what you've done is you've then gone into watchful waiting mode.
Well,
and that's risky.
I'm sort of
you don't necessarily need to get biopsies done, but get the PSA done, you know, at least once a year. You know, after you've got a whole bunch of years where you're running clean. Twice a year is probably good. It's a blood test.
Yeah, it's not a big deal. It depends on your doctor. I'm getting it once a year, but I'm not saying that. I kind of see that as a concierge approach to it. It's individualized, you know. So Willie, you know, it kind of depends what's going on with you. I mean, if you're very low risk, you know, discuss it with your doctor. So,
and maybe it'll become easier with the urine test coming up.
Well, I mean, Dr. Klotz was talking about that.
Yeah.
So
then it'll be much better and easier.
They've replaced my biopsy with an MRI every couple of years.
Well, I think that you know, I'm writing something about this. Several of us were on an international consensus panel. I don't know if it just got published today. I have an article coming out of my newsletter, probably Monday, maybe Sunday, about this. And basically, I don't know if the other guys have read the article, but what the conclusion of the article is the U.S. has too many biopsies and not enough MRIs. So Willie, I think your doctors are following the right approach. You know, it should be MRI first. You know, the MRI can find if there's something suspicious. It does potentially miss things, but you know, you're saved from whatever the risks are of a biopsy. So, but
there's also what are known as, you hear them called liquid biopsies, liquid biomarkers, and those are not specific to giving you a Gleason score, but they will give an indication to the doc as to whether or not you have anything in your bloodstream. So they're being used more. Select MDX and ExoDX are two of the ones that are used to be able to determine whether or not a biopsy might be suggested. So minimizing biopsies is good. There is no one tool.
Well, and you know, just to finish the thought, I'm going to give a plug to my newsletter, the activesurveillor.com, one word. I'm going to be posting a story probably tomorrow, maybe Monday, about this consensus panel of patients, and several of us from US and Canada were on the panel, and we're here today actually. But the biggest takeaway I got from this was that not enough biopsies are being done reverse that. Not enough MRIs are being done before biopsies. And also the panel recommends an end to the finger wag, the digital rectal exam. So, I'll post my newsletter address now. Now, who else wants to talk. Joe, do you have some?
Howard, could I interject here?
Yeah.
We had a question from a C. Foster concerning Propecia. And I'll just read it in the interest of saving time. Will Propecia use increase chances or cause a 3+3 cancer to progress to a higher level? I think the answer to that is no, but Propecia is important in this analysis. And you need to tell your doctor if you're using it, because Propecia can actually have the effect of suppressing PSA. And I actually saw this in a case within the last couple months, a guy that I've known for a long time. Both of his brothers were diagnosed with prostate cancer. And so he called me up and we were talking, and his was fine, but he was using Propecia. And my advice was, you better get that checked out, because Propecia can in fact suppress PSA. And lo and behold, he had high volume 4+3 and had surgery a few days before Christmas. So it is important. I don't think it stimulates progression as such, but in terms of figuring out what you've got, it's a relevant factor.
Well, Jim, what about the other side effects? I mean, Propecia and is similar to these other drugs. I don't know if it's the same as finasteride and.
I think it is.
It is finasteride, and it's just a different consistency of it, and it is sometimes used to try to shrink a prostate. Okay, that's one of the alternatives. And yes, Jim, it's very good advice to say if you're on it, but your doctor should be telling you. But of course, maybe this doctor was using the Propecia for hair loss and not for prostate.
Well, they were different doctors.
So were the doctors consulting with each other? And there's other side effects to it, not necessarily common, but there was a study that came out in the last few weeks talking about depression in a very small number of patients. Also breast enlargement. Yeah, we had one of the guys in one of the support groups talking about his having that experience. So, I mean, when you take drugs.
That's usually on the ADT side of the house. And when we.
No, but finasteride can cause that as well, Joe.
Howard, there's a question from Brian that relates to what Jim was just talking about, where he's asking whether a Gleason 6 3+3 can actually turn into a 7 3+4. If you wanted to address that, and of course, Dr. Klotz, correct me if I'm wrong, said in the video that there was a 1 in 5 chance of that happening over a period of 10 to 15 years. So it's extremely low that would happen. But this is Brian.
I appreciate that. And I can add something, but maybe some of the other guys can add more. I mean, Klotz also, referred to the fact, and he has in the past, and some of the other doctors have as well, that if you have a Gleason 6, it never converts into a deadly cancer. It never spreads, but what they don't know is if adjacent to it, you have a Gleason 4. For example, or even something higher. So, when you go on active surveillance, and they've only found a Gleason 6. Some of the doctors are worried what's adjacent to it. So, Brian's asking, does one convert into the other? And I think it's, and tell me if I'm wrong, guys, but I think it's more a matter of, you got a Gleason 6, you got a Gleason 6, but maybe adjacent to that, you have cells that are Gleason 7.
I can
Well,
give you, I can give you an instance where that is the case, Howard, because you know, in my case,
Yeah.
for 3 years, I was tracking Gleason 6 between biopsies and PSAs, et cetera. And sure enough, there was another lesion hiding, which turned out to be a Gleason 8 and became a 9, which is why you'll hear me pitch all the time, be active. Don't go sitting back and just assume that everything is just great. Get the periodic testing, and then if something does come up, as in my case, I was able then to go into treatment.
And of course, that emphasizes how important imaging is.
Yes.
You know, I see Christopher Stewart is asking some questions about Decipher. And, you know, I just feel a sense of mystery when Decipher is mentioned. Because like we heard the tale of a guy last week who on every indication was low risk. And he went to a couple of major institutions and they wanted to do surgery on him. And in the end, he went to Joe's doctor at Fox Chase in Philadelphia. And, you know, Joe's doctor said that this patient was so low risk that maybe he should have never been given a Decipher test. But Joe, you're really good with those tests. Maybe you could comment on Christopher's questions.
Well, Decipher is got a built a reputation for being a little bit more pessimistic than the others, and it's like anything else. It's a test, and it's administered and run by some specialists. And sometimes you don't get exactly the true reading. That's why I'm repeating myself from before. Don't go with just any one indicator. You take the combination of that. Someday there'll be something magic, and we'll get the Star Trek tricorder out, and we'll be able to figure everything out. In the meantime, it's one element, and that particular advice that was given to that one patient was the fact that maybe there was something wrong with the test. Maybe it was the way that the Decipher people ran it. You know, that's why you look at multiple indicators and then make a decision based on that one. The other two major ones, and you'll find that when you come to the presentation Monday night, you'll find out that Schultz is more a favor of Oncotype DX. Okay, but Oncotype, Prolaris, and Decipher are the three major ones that are used.
Let's see, who else are we missing here? You know, I'd like to hear from Igor if he's around. I wonder how he stumbled into this meeting from Moscow. Igor,
Igor, I don't think is showing up on the system anymore. I was just looking.
Oh, too bad.
I think we might have lost him.
I've lost it in the chat box at this point, but there was a question about how do you get a BRCA test? And Joe, maybe you could talk to that a little bit about the PROMISE study. It's really not a BRCA test per se. It's one of the things that they look at in a comprehensive genetic workup. And if you've been diagnosed with prostate cancer, you can get it for free and help yourself and help them build a database. Joe, do you want to?
Yeah, Jim, maybe before Joe, if I could clarify that, maybe Joe, do you have the link for the PROMISE test? The PROMISE test looks at our inherited DNA, and BRCA is short for breast cancer, and that's where the bread and butter for that test came from. But it turns out that even men can inherit that gene, and that gene is associated not only with breast cancer and cervical cancer, but also prostate cancer. And so the PROMISE study out of Johns Hopkins and a couple of other major institutions offers a free test of your inherited DNA. These other tests like Decipher and Prolaris look at something different. They look at the DNA in your cancer. Your cancer has its own DNA, and these tests predict various things. Are you should you be having a biopsy? Are you at risk for more aggressive cancer? So, Joe, I'll turn it back over to you.
I'm gonna put that in the chat momentarily. The it's prostate cancer promise, all one word, .org. And they're doing a particular study. They're reputable docs in the prostate cancer arena. And as Howard indicated, it doesn't cost you anything. They're trying to get 5,000 participants, of which there are going to be 500 monitored on a long-term basis. But it will give you using the color test, but it will give you indication as to whether or not you have any inherited mutations.
Funny thing, I took that test, Joe, and you get a genetic counselor. I had nothing with prostate cancer, and I know that's what the meeting's about, but I was at risk for an Ashkenazi Jewish brand of colon cancer. My mom died from colon cancer, and one of my brothers and my sister both took the same test, and they both inherited the gene. I have another brother who has his ostrich head out in the ground. He hasn't taken it, but it's a free test. It would cost $300 otherwise, only available to American viewers. They're trying to expand to Canada. And I should mention in an upcoming episode, actually we have 2 episodes with one of the researchers in the test, and he's a Canadian genetic counselor, and he's trying to get it made available in Canada, but it's otherwise $300. And Joe, if you posted it, I'd recommend everybody take advantage of it.
It's in the chat.
Yeah, we got a lot of chatting going on here. So
There are several other sources of getting germline testing, which is where you're looking for inherited. The list price on those can go up into the thousands, but it's covered by most insurances. Again, sorry, Canadians. Even though Joe McGowan indicated he can use a U.S. address and probably get it covered. That's not an official statement.
But, it was interesting to hear Klotz recommending, genetic testing to Larry White in the video. And then he made a big point of saying, well, we don't have it available in Canada. Same issue in Europe. I don't know how many Europeans we have in the audience, but genetic testing is a big deal in the US, but it doesn't seem to be a big deal anywhere else. So, at any rate, Joe, anything else on that?
Well, we really don't want to try to do a whole support group tonight on genetic testing, but the one thing that happens if your doc decides that it's a good idea, or you decide it's a good idea beyond the promise, you can also get it done through other sources. And I know from experience from many of the guys in some of our support groups that the commercial price is what they use when they decide to bill the insurance company, but the price is generally negotiable.
So now we have one of the participants asking about a term I've never heard. Have any of you ever heard of germide? Is that?
I think he means germline, I think.
Oh, I think so.
Yeah.
So I think we've got that covered.
Yeah, that's the basic genetic testing that we've just been talking about.
I thought maybe he was talking about germicide. I didn't know.
Yeah.
Now,
right, we really don't want to get too far afield now, Howard.
Yeah, well, now Joel Kleekamp, I don't know if he wants to ask his question. Joel? I can ask for them. How do you interpret the PSA following a TURP surgery, which removed only part of the prostate due to BPH? One answer to that is a number of guys end up getting diagnosed with prostate cancer, as a result of tissue sampling after a TURP. That's how I interpret it. And I should add that typically those cancers are very low risk. Does anybody else have anything for Joel on that? Nobody?
Joel might want to come to the Schultz webinar and present that one. That's a little bit more technical than maybe what we should attempt.
Here's another one. Again, from my fellow Chicagoan, Michael. He's asking what a PSMA is. And Joe, you've had one. You're the expert. So is it ready for prime time?
Yes, absolutely.
It's ready. Go ahead.
It's becoming very prevalent now. Initially, when it came out, it's only been in the mainline production for a little over a year, or about a year now. And the initial indications was used for recurrent treatments. That's how they first started. Most, not all, but most prostate cancers have a membrane. That's where the M comes for, PSM for membrane. And the membrane can be activated by a test to light up on the screen and allow them to see where there is any potential metastasis beyond any presence in the prostate itself. So that's pretty much what the PSMA does. And that's where Klotz was referring to the fact that it's probably going to become more prominent. It's replacing the bone scans and the CT scans that have been typical all along, because it's more definitive, more specific. And
well, he also said it's likely in the years ahead to be used more for lower risk. But it's one of our guys has a Gleason 3+4, and he was able to talk his doctor in Columbus, Ohio, into having a PSMA, and Medicare covered it. But most of us with Gleason 6, or maybe all of us with Gleason 6, that's sometime in the future. And I have to say, I've been on this a long time, and there've just been radical changes as the years have gone on. You wouldn't recognize what I started out with, like totally different today. So any other questions out there?
We have about 2 minutes left to quitting time, folks. So if you have anything that's pertinent, please bring it up.
Well, there is one question from Brian a little bit earlier. It's a pretty general question about the difficulty of getting a PSA done with ordinary blood work that your doctor might order. And as we know that in some cases, PSAs are still not being recommended. Howard, if you wanted to elaborate on that.
Well, let's face it. I mean, it's a really complicated history with this. But in 2008, the U.S. Preventative Services Task Force, it's a non-governmental agency that makes screening recommendations for primary care doctors. And they said PSA was not recommended for anybody, I think it was like over 70. Then in 2012, they give like an ABCD unrecommended grade, and they gave PSA in 2012 for all of us a very low grade, a D. And there was a protest by the urologists and by many of the prostate advocates that the task force had goofed. So they gave it a C, barely a passing grade. And they said it was a matter of discussing it with your doctor, a shared decision. Thing is where the PSA starts is usually in the office of family physicians. And generally, well, let's put it this way, they're not exactly sold on PSA. And what we've seen is a decline in use of PSA. Highest numbers I've ever seen on that were out of Toronto, where they had almost an 80% uptake. 80% of men in some practice in Toronto had PSA. Highest numbers I've seen in the US are not that high. It was somewhere in the mid 40%. And after the task force said what it did, there was all this confusion and it dropped to like 33%. So, you know, is that a bad thing? Well, a lot of the advocates say so, because probably most of you saw the news that came from the Cancer Society on January 12th, where they said for the first time in 20 years, they'd seen that for 20 years, year after year, they saw a decline in prostate cancer incidence and death. And suddenly from 2014 to 2019, they do things in intervals like that. It reversed itself and they found a 3% per year increase. So, you know, whatever that adds up to. And some of the advocates say it was far more. If you look at the more current figures, which are really estimates of death. So this is a long story. I'm going to try to keep it short. So, you know, Brian, I don't know if it's a family doctor who's telling you not to do it. I can tell you, I know many physicians who've never had a PSA. My cousin in Arizona, well, there's two of them. One brother ended up with a Gleason 8. He had a test, and his wife's an oncologist, and he's been through the whole rigmarole of treatment. He had the surgery, but his PSA went up. Then he had radiation, and his PSA went up, and so now he's just coping. His brother, he's a retired rabbi. His brother was a plastic and reconstructive surgeon in Scottsdale, and he also spent half his time as a lawyer suing other doctors. And he never had a PSA. And he ended up dying about a year ago from heart disease, which is the fate for most of us. But anyway, Brian, if you want a PSA, you should ask your family doctor. I would expect that he or she would go along. I have a special kind of PSA test that combines 3 kinds of PSA. And so it has the regular PSA and it has the free PSA, which you mentioned. And it has some sort of logarithm where they combine this information with your age. It's called the PHI test. I don't get a percentage on it. It's short for Prostate Health Index. Memorial Sloan Kettering is a similar test. I'm told that it's not used often for monitoring, and that's the 4K score. And there's another new test, and that's from Cleveland Clinic, and it's commercially available. It's approved by the FDA, and it's called the ISO PSA. They make a big point of saying it's only for the newly diagnosed. It's not for patients on active surveillance, but I know men who are paying for it out of pocket and have persuaded their doctors to get trained, which is no big deal, in reading the test. So, I mean, there's alternatives out there. It depends where you are with your disease. Your doctor may not even know about the PHI test, but it's offered by a major company. Check out 4K. Let's see, you also say, medications prescribed by urologists. Isn't a modest decrease in PSA predicted? Well, not really. It's like a major decrease if you're taking things like finasteride, or I'm forgetting how to pronounce the other one, dutasteride. If you're taking those, you're
50%.
you have 50% decrease. So what they do when they get those scores back, they double them. So I don't know if that addresses what you're saying, Brian. Let's see.
Well, Howard, I think he was basically bringing up the fact or questioning that the PSA test, perhaps for him and definitely for others, is not a routine, it's not included in routine blood work, so that if you want that, you're going to actually have to ask your doctor for it.
It's strange, but it's probably true. I've had so many of those PSA tests. I think I made the Phi company rich, but it's not a very expensive test, actually. I just interviewed a guy for my newsletter. He's at University of California, San Diego. And what he is recommending is that men, without any discussion, have their PSA tested so they can find advanced cancers. I mean, I mentioned to you only 33% of men have the test anymore. He wants everybody tested and only told about it if they have, some risk factor that's showing up there, like a high PSA. And he would start intervening with PSAs of 1.5, which some organizations recommend. Then, if you're not in that category, what he says is he would let you go, and it would be like a colonoscopy. You'd come back in 5 years and get another PSA. So I don't know if that helped you, Brian. If you want to get more specific, feel free to speak up. But, we should probably quit in another few minutes.
Yeah, I think one of the things I'm going to reemphasize, and I just put it back into the chat so that you don't have to go trying to bury it out there. Really would invite you to join Dr. Schultz on Monday night at 8 p.m. Eastern, where he'll be addressing some of these topics, because I know some of the things he's going to bring into his presentation. His presentation will be akin to a lot of the ones that we have, about 40 minutes of presentation and another about 50 minutes for Q&A. If you have questions that you want addressed in advance, we'll take some of the ones here. We'll give them all to Howard. And
thanks a lot, Joe.
My pleasure. And we'll accumulate them, or you'll be able to enter your questions throughout the webinar, and they'll be accumulated and passed on to the doctor. You do need to register for it. It's not a drop-in session. You need to register it, and that then be provided a link.
Well, maybe we should wrap it up. We've kind of gone over time here.
Well, we appreciate everybody coming out. It was a good session. We will repeat the video. Everybody here should be getting a notice. Anybody who registered will be getting a notice that it's going to be posted on the ASPE website. It's already posted are the earlier programs. We have other ones on tape, and we're going to find some clever way of gathering them all together and promoting them so that guys, who are newly diagnosed or who are in the gray zone and haven't been diagnosed, and anyone else can find it easily. So I guess I'll thank you. Thank you for Mark Lichty, who couldn't make it today. But thanks for coming.
Thank you.
Thank you all.
Thanks.
Top of the afternoon.
Have a good weekend.
Thanks, everybody, for being here.